Good morning and welcome to everybody. We are discussing weaning of the patient from ventilator, a very interesting topic. Now the step 5 of this is to extubate the patient. After undergoing a successful SBT, a few more criteria should be fulfilled before deciding about extubation. Adequate cough reflex, spontaneously or while suctioning. Patients should be able to protect the airways and they should follow simple commands. Secretions should not be copious. A cough leak of less than 110 ml measured during assist control ventilation helps to identify patients who are at high risk of developing post-extubation stridor or obstruction of airway. No radiological or surgical procedure is being planned in the near future. Extubation should not be done at the end of the day. Step 6, that is monitor for extubation failure. After extubation, the patient should be observed closely for signs of extubation failure as mentioned below. Respiratory rate more than 25 per minute for 2 hours. Heart rate more than 140 beats per minute or sustained increase or decrease of more than 20%. Clinical signs of respiratory muscle fatigue or increased work of breathing. SaO2 less than 90%. PaO2 less than 80 millimeter of mercury on FiO2 more than 0.50. Hypercapnia, that is PaCO2, more than 45 millimeter of mercury or more than 20% from pre-extubation. pH less than 7.33. Step 7, that is try non-invasive ventilation. If the signs of extubation failure are present, the physician should try NIV, that is non-invasive ventilation, particularly in the conditions where its role is proved. For example, in COPD, post-operative failure after lung resection surgery, or decompensated obstructive sleep apnea. NIV has the advantage of reduced complications and better patient interactions. However, it is important to keep in mind that it should not delay the re-intubation if required. And every hour that a patient spends on the NIV when intubation is clearly required increases the mortality and delays the recovery. NIV is used in 3 clinical settings as an alternative weaning technique for the patients who failed SBT. Extubate and put on NIV, well documented role in the COPD patients without significant comorbidities and in centers with expertise in NIV use. As a prophylactic measure for the patients with a high risk of reintubation, studied in the postoperative patients, start NIV electively after successful SBT, that is spontaneous breathing trial, and extubation, as the treatment of respiratory insufficiency after the extubation, that is post-extubation failure, useful in the COPD. In conditions where the role of NIV is not proved, the patient should be reintubated. Reintubation carries higher mortality either because of underlying medical condition or because of possible complications such as aspiration or ventilator associated pneumonia. Step 8. Identify the difficult weaning. Weaning success is defined as extubation and the absence of ventilator support 48 hours following the extubation. Weaning failure is defined as one of the following: failed SBT, reintubation and or resumption of ventilator support following the successful extubation, death within 48 hours following extubation. The term weaning in progress is used for the patients who are extubated but remain supported by NIV. Difficult weaning. Patients who fail the initial weaning and require up to 3 SBT or as long as 7 days from the first SBT to achieve the successful weaning. Prolonged weaning. Patients who fail at least 3 weaning attempts or require more than 7 days of weaning after the first SBT. Step: ascertain the cause of weaning difficulty. Carry out a detailed examination of the patient and look for the cause of difficult weaning. Make a checklist based on the pathophysiologic mechanisms. Number 1, inadequate respiratory drive. This includes the nutritional deficiencies, excess of sedatives, central nervous system abnormality, and sleep deprivation. Number 2, the inability of the lungs to carry out gas exchange effectively. It includes unresolved pneumonia, unresolved pulmonary edema or fluid overload, undiagnosed pulmonary embolism, the splinting effect of obesity, abdominal distension or ascites. Number 3 is the respiratory muscle fatigue or weakness. This includes nutritional and metabolic deficiencies, critical illness like polyneuropathy, myopathy, hypokalemia and hypomagnesemia. hypocalcemia, hypophosphatemia, hypoadrenalism, hypothyroidism, corticosteroids, myopathy, hyperglycemia, chronic renal failure, systemic disease sepsis, impaired diaphragmatic force generation. Hypoadrenalism, hypothyroidism, corticosteroids, myopathy and hyperglycemia, and chronic renal failure, systemic disease sepsis, impaired diaphragmatic force generation, refractory hypoxemia and hypercapnia, persistently increased work of breathing, ineffective triggering, auto-PEEP, increased resistance due to ventilator tubings or humidification devices, poor cardiac performance, neuromuscular dysfunction or disease, drugs. Then we come to number 4, that is the anxiety. It is difficult to distinguish anxiety from ventilatory failure. If in doubt, always presume it to be ventilator failure. Psychological dependency in difficult weaning. Okay, we come to the end of this session of lectures. We'll come up with next group of lectures from the next day. Thank you.